You are most welcome, ladies and gentlemen, to your power behind the voice on Tuesday Night Anatomy with Daniel Okwan. Yes, we are still in the era of anatomy of clinical importance. And my friends, this is today's case study. A 35-year-old man was involved in a motor vehicular accident resulting in fracture of his left clavicle and left first rib. Yes, the overall assessment by the attending physician revealed that, by way of prognosis, predicting what the outcome of this one will be, the doctor indicated that it was not so good. Now, this is the case study we have, yes, before us at the moment. And the first question that I am going to ask you is that the fracture of the clavicle, yes, it could take place at, any point. But what is the most likely point for the fracture of the left clavicle in this regard? My friends, your answer that often we give is at the junction of the medial two thirds and the lateral one-third portions of the diaphysis or the shaft of the clavicle. My friend, that's often the answer we give, and then we are not wrong. But even some clinical studies, yes, has told us, we've got some kind of, findings that it is better we say that the junction of the medial 3/5 portion and then of course the lateral 2/5 portion of the diaphysis of the clavicle. Okay, so whichever way that you present it, either you talk about the medial 3/5, yes, and of course the lateral 2/5 of the junction that we're talking about, or we talk about the medial 2/3 portion and of course the lateral 1/3 portion, the junction of these two. Now, the question number 2 that is before us is that now this patient, was experiencing some kind of excruciating pain, emanating from the fracture of the clavicle. Now, what accounts for the pain that this patient, yes, is of course experiencing? My friends, your answer that I want you to give is that as far as the diaphysis of this bone is concerned, we have what you call the periosteum of the bone. And my friends, this periosteum will contain some nerve fibers, which will carry, the pain. So these nerve fibers which are responsible for carrying the pain, are those ones, yes, which, is resulting in that kind of excruciating pain that the patient is experiencing due to a fracture of the clavicle. So understand that these nerve fibers will contain nociceptors, so that they can carry the pain from the diaphysis of the bone. So this is question number 2. Now, question number 3 is that the doctor, by way of helping students to learn some of these things, presented this case to, of course, some medical students. And one of the remarks that the medical student gave was that rib number 1 is actually a true rib and at the same time an atypical rib. So now, what is the reason why this medical student gave this, this remark as far as rib number 1 is concerned? My friends, we call rib number 1 a true rib for the reason that it has its own costal cartilage articulating with, of course, the manubrum of the sternum, directly. That's the point. So if you are a rib and you have your own costal cartilage and you are able to articulate directly with, of course, whichever area of the sternum, then you become a true rib. And that is why true ribs are also called vertebrosternal or vertebrocostal ribs. So understand these things. Now, it's not only rib 1 which will be called, a true rib, because of course rib 1 all the way to rib 7, all these ones will be called true ribs. But my friends, by calling rib 1 atypical, What are the reasons? Now, the reason is simple. First of all, it has a single facet on its head. Now, we expect that if you are a typical rib, you are supposed to have two facets on your head. Okay, a superior and of course an inferior facet. But rib number one has a single, articular facet. Yes, for articulating one, of course. The facet on what we call the body of, in this case, the corresponding, thoracic vertebra. Okay, so what I'm trying to say is that rib number one is atypical for the reason that it is not having two facets on the head, it's rather having a single facet on the head. But my friend, that's not all. It is also atypical for the reason that it is the widest, first of all, and it is also the shortest. So it is the most stout, okay, the stoutest, rib that we have in the human body. That's the first thing. Okay, so that gives you two reasons. And then the third reason is that if you look at its superior surface, it's rough. Now, what contributes to the roughness on its superior surface? Yeah, because at the end of the day, we have what we call the tubercle for what we call the scalenus anterior muscle where it inserts, and then also anterior to that one, we will have the groove for subclavian vein, and then posterior to the tubercle of scalenus anterior, we have the groove for, of course, the subclavian artery. In this case, the left ones that we are talking about. Okay, so that is one thing I want you to become aware of, because at the end we are talking about the left, first rib. That is what I want you to understand. Well, the same thing happens in the case of the right. Okay, so there's no really, difference in this regard. Okay, now the next question, which is question number 4, is that, what made this clinician, okay, indicate that, of course, the prognosis wasn't so good? Now, the reason is simple, that there will be other structures which relate, especially to rib number 1, okay, that will also are likely to get injured. Okay, and what are these things? We just mentioned them. Now, one of them is, of course, the subclavian vein. If there's the subclavian vein, then of course, venous blood, there may be that kind of loss of venous blood. Okay, that's one thing. Now, even the loss of venous blood is not as, very important clinically, okay, compared to, of course, loss of, arterial blood, oxygen-rich blood. Coming from where? Yes, so there's that kind of likelihood that there will be fracture of what we call the left subclavian artery. And when that happens, there will be that kind of great deal of loss of, oxygen-rich blood, full of nutrients and what have you. So the patient will lose a lot of these things. And that's why the prognosis is not very good in this sense. My friends, another thing about, other things that can happen will be, of course, avulsion, okay, because I've told you that the insertion point of what we call the scalenus anterior muscle or the anterior scalene muscle is on the first rib. And so there's that likelihood that there will be that kind of avulsion, okay, it will lose its attachment on the first rib by way of the scalenus anterior muscle. Now, one other thing too is that getting a bit more posterior, we appreciate that also there's also an insertion point for what we call the scalenus medius muscle. Although it doesn't leave that kind of great impression over there, but it's also, related to the first rib. And so likely, scalenus medius or middle scalene muscle may also experience this avulsion that we are talking about. But my friends, all in all, the most important point which I want to know, which has bearing to the respiratory system, is that whenever rib number 1 gets fractured, one important thing that we know about rib number 1 is that it gives attachment, okay? It's, inner surface gives attachment to something that we call the suprapleural membrane. Something simply we call the substance fascia, that's the eponym, substance fascia. Now, this substance fascia is more or less like bridging what we call the, superior thoracic aperture. Okay, that's what we see. And my friend, once I move from this superior, thoracic aperture, that's the communication point between the neck and of course the thorax. Just, okay, in this sense, we are talking about the left one, just above just below actually, the superior suprapleural membrane or the substance fascia is, my friend, the apex of the left lung. And so the likelihood that if rib number 1 is injured, there's that kind of likelihood that it could result in that kind of injury or puncture through, of course, the suprapleural membrane, and for that matter, of course, that of the apex of the left lung. And so, my friends, I want you to understand these things so that, of course, whichever case that is before you, you can clearly, explain them. My friends, I hope you find this meeting helpful. I'm very grateful for your time this evening. Have a good night, all of you, and may the good Lord richly bless you. Amen.